Just like to say good evening, everybody. Welcome to tonight's Health, Housing and Adult Social Care Scrutiny Committee. My name is Councillor Jane Burton, and I'm chair of the committee. We have some apologies for absence. Councillor Maroney is not here this evening, and Councillor Clark is subbing for him. Councillor Wan is not here, and Councillor Waller is subbing for him, and Councillor Smalley isn't here, and Councillor Fenton is subbing for him. So welcome to you all, and thank you for coming. Do we have any declarations of interest? No. Okay. Okay, so we're going to now go through the minutes of the meeting of the 12th of March 2025. Has everybody had a chance to look at the minutes, and do you think they're a good representation of the meeting? Yes, there is. Yes, sorry. Councillor Bassey.
Thank you, Chair. I think the minutes are okay, but going through them reminded me of something that we'd asked for in December that didn't happen in the report that came to us in March. So I just wanted to flag it up, because I think the whole committee agreed it was something that was important and would be helpful. And we don't know what's happening with scrutiny going forwards, but I still think it's important. So in the finance and performance monitoring figures we got in December, I remember specifically raising the issue of the vagueness of figures that relate to different service areas in adult social care. And we discussed the fact that there's direct payments, home and day support, supported living, all the different categories, but that all we were being given was a total spend. And there was never any breakdown as to how many people were helped in those areas and the per capita spend in each of those areas. And we discussed at some length that it would be helpful to have that data when you compare home and day support with nursing care or whatever, to get a sense of the relative spend. So we asked for that in December. When I looked again at the report for last month, I realised I should have raised it then, and I apologise, but those adjustments have not been made. So I'd just like to suggest that we consider maybe making a note,
certainly,
for the future, that we have asked for that and that we did agree that it would be helpful.
Yes, I know that we did go to a bit more specific on costs and how many it was rising by and why. But I've made a note of that, and I shall write to the necessary person involved and raise that, because I think it was very it is quite useful.
Yeah, just an additional similar comment, I guess, is my experience across all scrutinies and committees is that most of the requested changes to KPIs and things on York Open data haven't really been made. Whereas, for example, last time around we had a really good report. The report had loads of details we'd asked for previously and fleshed it out really effectively. So, yeah, well, something to take away, potential York Open Data Task and Finish Group to look at KPIs, etc., to try and actually own this going forward, to not just continually add more stuff to it, but if the changes aren't being made and if we've got too much data, how do we actually structure it better and make it a bit better? And A&G, we had a good piece around how we could better visualize data and use some of the kind of Power BI type software over the top of it. So I think there's scope for a proper deep dive into that area at some point. But if we can make the changes that have been previously requested, it's a good starting point, isn't it?
Yeah. Councillor Runciman.
Yes, it would be interesting to ask, but complicated, I think, because if you get some areas of spend, there's a lot of spend supporting very few people. And in other areas, there's same amount of spend, perhaps supporting an awful lot of people. And it needs explanation. It's not just sufficient to have numbers.
Yeah.
So I think we need to ask very carefully for exactly what we think we want, rather than just bold numbers.
Yeah. Very good point.
Chair, and hopefully because the executive members here, I hope the executive member also sees the value in this, because it's very difficult in the abstract to just see 2 million spent here and 5 million spent there, and not get a sense, as Carol Runciman says, you know, that's part of it too. Who's being helped? What degree of help do they need? So we can better participate going forward.
Absolutely agree, Councillor Vassie. But as Councillor Runciman says, really, really important to have the narrative there, because otherwise it can look like very vast sums of money are supporting very few people, which is why it needs to be directly related to a person's need. But yeah, absolutely agree.
Yeah, okay, that's very good. There was actually, going back to the minutes, there's a typo on page 9. I've pointed that out and that's going to be corrected. But apart from that, everyone's happy with the minutes? Yeah, so the minutes are passed for signature. Very good, thank you. Okay, we're now moving on to the next part of the meeting, which is public participation. And we have Flick Williams, who's going to be speaking remotely on matters under the remit of the committee to do with pharmacy issues and supplies of medication. So can you hear me, Flick?
Yes, good afternoon.
Good afternoon. Welcome to tonight's meeting. And you know the score, you don't want a warning, do you?
No, thank you.
Okay, over to you. Thank you.
Given this committee's recent discussions on pharmacy provision, I'm here today to share my experience of last Friday and invite members to consider the ramifications against the wider agenda being pursued by government. Already exhausted from a week of protesting against benefit cuts, I went to collect my prescription medication. The one drug I really need was out of stock, including at the wholesalers. The pharmacist gave me my script back to try and get it filled elsewhere. I returned home and was on hold for 25 minutes with my GP's prescription line. I explained the issue. This medication is one that when you start taking it, you must take it for life, or the consequences are worse than before. I've been on it for 5 years. I was told someone may call me back and it may not be today. I said, but it's Friday and I run out on Sunday. I concluded this was yet another you do you problem that I must fix. So I charged my wheelchair and set out. Pharmacies 2, 3 and 4 were also out of stock, and now I've run out of the accessible ones. Pharmacy number 5 has a step and a bell with a wheelchair symbol that doesn't work. I get another customer to alert staff attention. The pharmacist comes outside. Yes, they have the drug in stock. Do I have it? Not even close. The barcode on the prescription my pharmacy has printed is faulty. They have been phoned. Nothing they can do. Pharmacist suggests I phone my GP surgery. I explain I've already done this and now away from home have insufficient credit on my phone to do so again. I am upset now. I persuade the pharmacist to ring the surgery. Another 20+ minutes elapse. She returns to say they have reissued the prescription, but it may take some time to come through as the system is busy. Eventually, after sitting outside in my wheelchair for over an hour in 29-mile-an-hour winds and spitty rain, I have the vital drug that prevents me from ending up in hospital, where I absolutely do not want to be because of the COVID risk as a clinically vulnerable person who is vaccine injured and consequently unprotected. The final blow, they only have one box, so we'll order the second and text me. No text, so I assume they cannot now order it either. This is now the 3rd time I've been on a pharmacy crawl for this drug. The system prevents stocking up to avoid a cliff edge. Many disabled people I know are adversely affected by drug shortages and problems in the supply chain. A classic tale of for want of a nail the shoe was lost, etc. The Combined Authority Inactivity Trailblazer waxes lyrical about joining up systems and services with no clue as to the real barriers to daily disabled living. How many employers are willing to give a day off a month to go hunting down medication? Thank you.
Thank you for your comments, which we will note and pass on to the relevant parts of the council, to the ICB part of the pharmacy part of the ICB as well. I'm sorry to hear of your experiences, very distressing. I'm glad you got them eventually, but what a palaver. Thank you. Okay, right, we're just going to move on to item 7 on the agenda, which is the work plan. We're taking it in this order because we're awaiting one of our speakers who is slightly delayed in getting here. So we're taking it in this order, which is one of the reasons also why we've started a little bit later today. So looking at the work plan, has anybody got any comments? Also bearing in mind that with the changes to scrutiny, we're not entirely sure what will be, what our future will bring. If you look at the page 31, we have got the next meeting. We hope to have the draft autism and ADHD strategy, trauma-informed city, the update from the TU and NHS Trust, and hopefully we've asked for further update on urgent care delivery from, I think it's Nimbus Healthcare, who are running that service, if I remember rightly. We have unallocated items, and there may be items that you wish to add to this list as well. So if you have any ideas or concerns or anything you want to add, please speak now. Councillor Rose.
Yeah, I mean, I don't think we should spend a huge amount of time talking about the work plan, given that we will cease to exist. But I think it also makes sense to not go in cold to the new structure. So in addition to the unallocated items we had at full council, the council resolves to request the relevant scrutiny committee to undertake a review by a task and finish group around the disability and PIP situation. So I think that should be on the equivalent of what we are going forward. Other than that, I think the list is all right, and we've got May sorted, so it'll be up to whatever the new structure and how that splits.
Yes.
I guess
mean,
half
these
of our stuff,
issues will
housing
be
is
still covered, so yeah.
Of course, but yeah, we'll
Yeah.
have 2 different chairs in charge of the one set of items, because all the housing stuff will be placed and all the health will be people, I guess, in the new structure. So yeah, no other thoughts from me.
Yeah, but that's, have you got that? Yeah, that's definitely where, so the task and finish group on the welfare and disability cuts. Yeah, everyone's okay with that? Yeah. Councillor Massey?
Just to add to that, I agree with those comments. These unallocated items show us the degree to which, with all the committees we've got, we've struggled to look at all the subjects that needed to be looked at. That's a little concerning, but I think what it should do is focus our minds on making sure that we pick the topics that come to the public meetings carefully and make best use of the informal meetings to get a sense of what it is we can progress effectively. Because there are things here that have been on this list for 18 months, 2 years. And there's nothing on here that's not important, but we have struggled to prioritise and get things done. So we'll have to work hard under the new approach.
Yes. Councillor Fenton.
I think the changes that are coming give us an opportunity through necessity to look at items that have been on work plans for some time, to try and identify why did we put it on the work plan to begin with? Is it that we want to better understand what's happening in this particular space? In which case, a briefing for members would be the route to go, which may lead to an item on a formal scrutiny committee or a task and finish group if that if that discussion phase, that exploration phase turns up issues that members want to explore. So I'm hoping that we can get a sort of a toolkit for all members of scrutiny committees so we all know the rules of engagement. Otherwise there's a risk every committee will in the absence of any kind of guidance just go off in different directions. So I'm meeting Lindsay Tomlinson tomorrow, after which hopefully I'll have a better idea of where we're going, and then we can share information. And because we do need to set up a working group
Yes,
of, I think, current chairs and vice chairs in order to work through the various changes. So it's important not to lose the items that you've got on your reserve list, because they can go forward in whatever format, whether
absolutely, yeah.
Yeah.
And I think some things are coming back, aren't they? I mean, it's like in the next meeting, there are 2 items that have already been before us, but we wanted an update, and they're coming back in I think, quite a timely fashion. So we're keeping everybody on their toes, hopefully, as well. And I don't know, I don't think of the task and finish group as an informal way of, I still think it's it's a different way of dealing with some of these topics. Certainly from my experience, it's a different way of working, but it's quite an effective way of working if it's done well. Councillor Rose.
Yeah, just two small things to add, I guess. Number one is that there are some people who have concerns that taking stuff out of the public meetings might reduce the level of scrutiny. But I actually think there are times when we've had a 12-minute item on the agenda that might end up being 3 full meetings of a task and finish group with a huge amount of scrutiny attached to it as a result of the change. And picking the example that we've got from full council, we've just heard from Flick about a number of ways in which people's experiences day to day related to that are massively impacted, and that task and finish can incorporate all these extra things. Whereas if we just had a paper on it just to one meeting and then asked a few questions, that we might not get into as much of the detail around it. So I think there's definitely merit there. And I think the one thing I mentioned on the scrutiny review conversation was around how we can try and link back to when it last came to a committee. We can point to where people can look for the background information. And if we're changing memberships and changing screens, I think it's a good opportunity to do that as well, because there will be people who, when they come to the P&A conversation in September, won't necessarily know what a P&A is, whereas we've talked about it quite a lot over the last 6 to 12 months. So a good opportunity for us to all kind of retrain and realign, but fully agree with Stephen's point around us actually having to have a consistent plan and approach to it.
Yes.
Yeah.
And just for sort of your reassurance, we did have a meeting about the PNA with the ICB and various other key stakeholders on Friday, with ward councillors and cross-party membership, which I think went really well. So we're keeping it not on the back burner, we're keeping it boiling, I think, really, which is what we need to do. It's what we're here for. Councillor Bassey.
I think as well, since this is in a sense the goodbye to this particular scrutiny approach, a thing that we've struggled with for many years, and I know I've raised on a number of occasions, is we are over dependent, in my view, on receiving reports presented in a particular way, as if that's the only way to access the information that is helpful to us as human beings representing people in our ward. We've still got on here the item about health and artificial intelligence. We've talked about how technology can be used in adult social care. We've tried to set up a meeting, and I know we're still doing it, to go and see the work that Be Independent does. I think going forwards, it's worth making that effort to find different ways of engaging with the topics we engage with, rather than relying entirely on these reports with their paragraphs, with their formality, because it's not the only way to learn. So hopefully in the months ahead, we'll find ways together that we agree to access information differently.
Yeah, absolutely. So with that in mind, is there any other comments on the work plan at the moment? Nope, good. Okay, so great timing there. We're now going to move on to items 5 and then item 6. Would you like to do these separately or together? Would you like to present one after the other? Because they are related. Which would be best for you? Sorry to ask you.
Yeah, I think they are related and there is some kind of crossover between them. So I could start with an ICB update and then if Peter adds on the local authority side.
Yes, so
Yeah.
that's great. Thank you very much. So first we have Debbie Ledbetter, who's the primary care programme lead from Humber and North Yorkshire Health and Care Partnership. That's relating to item 5 on the agenda. And then we have the paper on oral health in York, which is Peter Roderick, who's Director of Public Health. And they are related. So over to you two. Thank you very much
Lovely, thank
for
you.
joining us.
Thanks for having us back as well, because I do recognise some faces because I've been to Health Wellbeing Board and other meetings as well. So it's good to come along and offer a further update. So thank you for the invitation. From the ICB's perspective, I suppose just that reminder that we took over the responsibility for dental commissioning in April 2023. So 2 years on, it's kind of an update of where we've got to, what we've achieved and what challenges are still outstanding across the whole of the ICB. So just as a reminder, in terms of what the ICB commissions, we look at the primary care dental services. So those are what you typically think of as in terms of a dental practice in the city. And all of those are commissioned on what's called a unit of dental activity. So one patient doesn't equal one unit. So it becomes a bit complex depending on if you need crowns or fillings, etc., as to how much that is. But we also commission community dental services. So in York, that's provided by Harrogate District Foundation Trust, and that's for more vulnerable adults and vulnerable children who maybe can't access a standard dental practice. We also commission intermediate minor oral surgery, orthodontic work and urgent care appointments, as well as a number of secondary care specialist kind of oral surgeons and other procedures that happen within secondary care. So we've got the remit for all of that, but we work really closely with the local authority around oral health and prevention messaging as well, and any services around that aspect. But in terms of locally, for what we are directly responsible in the ICB, we are working really hard to kind of build those relationships with providers, to work with everyone to improve the situation. But there are still those challenges that I know I've talked to you about before in terms of the dental contract itself, workforce issues, and procurement restrictions as well. So we're kind of a bit restrained by what we can do in terms of that wider context. Despite that, we have had some really local successes across the city. In particular, in 24-25, we have increased the number of staff in the dental team. So we've got a deputy director in place as well, who's offering that strategic leadership for us, as well as the team on the ground that liaises with our contractors and looks to procure new services. We have finally managed to get a new dental service in Monk's Cross. So that opened in December. And that was as a result largely of the Bupa hand back in 2022. So that's how long it can take to get a new dental practice in when we have a hand back. So we work really hard to avoid handbacks. Last year, we had a contractor contact us who was thinking about handing back their contract. We managed to work with them. We secured them. They're still in the city. They're still offering NHS appointments and a number of urgent slots as well. So we are working hard to avoid handbacks where we can. We've also got, as well as our funding for each contract, we have a non-recurrent budget that we can invest year on year. So it's harder to manage in terms of letting providers know in advance what we want, but it allows us to flex and change what we can ask for. So our non-recurrent funding in 2024, we really focused on urgent appointments, so linking with NHS 111 to get access for patients in need of an urgent appointment. So we've got 3 practices in York, and they offer around about 7,300 patient appointments per year. So reasonable numbers, hopefully, like across the whole country, with that kind of pressure and focus from national government to really improve access to urgent dental appointments. We know it's not enough, but it's a good starting point really within the city. And we've also got one orthodontic practice who has increased their capacity to see young people from the waiting list as well. We've also introduced child-only contracts. So we've got 4 practices in York that are taking part. So this is a bit of a pilot to see how it goes. And that includes one private provider that opened quite recently, but we've been able to secure an NHS child contract with them for a short period of time just to test out what that might look like. We continue to work with our local dental committees to really seek their input into future developments. And we've also are in the middle of a campaign, an oral health campaign that we're funding, again, targeted at children and their parents and carers and at young people around prevention, with that focus being really if we can get in there early, develop habits and routines around oral health, that hopefully then they wouldn't need urgent appointments in future, urgent needs as they get older. So that's running now. It started in March until mid-April, and we've got an evaluation around that as well to see what impact that is. It's predominantly through social media, through TikTok and things that young people use that I'm not entirely familiar with, but that's the route to go down. We're also exploring opportunities at the minute to focus on children and adults with neurodiverse conditions. So recognising at the moment the pathway is really a referral to a specialist. So those individuals end up sitting on waiting lists and waiting for their dental treatment, whereas actually working with Leeds and some specialists in Leeds, the view is that really if high street dental practices made adaptations to the environment, to appointment times, etc., some of those with neurodiverse conditions could be seen in a mainstream practice. So we're looking at how we can do that, and Leeds University are linked in a student with us to do some research around that. So it's quite exciting development area. We do also always focus on the most vulnerable. So we've got a flexible commissioning approach, which allows us to move away from that unit of dental delivery aspect of the contract, and actually lets us be more flexible in what we want to commission and what we want to deliver. And that allows us really to focus on the most vulnerable. So there's referral pathways for children in care to get access to those dental practices. Equally, we're really well linked in with Health Watch and some of the charities around women living in refuge or fleeing domestic abuse, and other vulnerable groups like that, where we can actually get mainstream quicker access to dental appointment if they need something. So flexible commissioning allows us to do that. We're currently just launching a continuation of that programme. It ended on the 31st of March, so we're just tweaking some of the requirements around it, and we're working with the practices to retain them on, and to hopefully in phase 2 open it up to even more practices joining that scheme. And we've also, for the second year in a row, have worked with our contractors to use some of that non-recurrent funding to allow them to deliver above and beyond their contracts. So they can deliver up to 10% above their contract, which improves access to patients. Initially, because we weren't sure what that funding would look like, we asked for expressions of interest. So we only had 2 practices in York who came forward. And so throughout the year, they've been working toward that. But in March, in that final push, we've reviewed the budgets and we've opened it to all practices. So there may be more appointments that were happening throughout March to try to turn up their access. We won't know the results of how positive that's been or what the impact is until later on in 25-26 when we do the final year accounts really for those practices. We also support what's called the Prevention Access and Treatment Programme. And this is something we really do strongly in collaboration with the local authorities. The key focus is around oral health improvements and working within schools. And I suppose it complements really what the local authorities have done traditionally in terms of supervised toothbrushing, but it adds an element of fluoride varnish, and also if dental issues are noted in the children, that child and their family members are invited into the practice for an appointment as well. So it kind of recognises that the child in isolation is likely to be the only one who needs support, so they open it up to their wider family as well. So across the ICB, so the whole of Humber and North Yorkshire, we have more than 90 schools taking part. It was initially a pilot, which started in Hull and East Riding, and we're rolling it out and still working with each local authority to identify more and more schools to participate, more and more practices to be part of that. And I know Peter's paper references that particular scheme as well. So it's really working quite well and a good chance for us to collaborate together. I know I mentioned before, one of the challenges that we do face is around workforce. So locally, we have been trying to address some of those issues. The national government did help in terms of offering a scheme called a Golden Hello or a dental recruitment incentive. So we've rolled that out. We approved 27 applications across Humber and North Yorkshire. 3 of those were based within York. The selection was kind of based on our local process, considering hard to recruit areas. As you know, York is quite an attractive place to live and work. So it's always a challenge kind of how we can include York in some of that. But we also looked at access levels and levels of deprivation because we know there's pockets in different areas. So we did get 3 placed within York. Overall, it has been really difficult to still recruit dentists, despite offering it's £20,000 over 3 years. So it's £10,000 in the first year and then 5,000 and 5,000. Humber and North Yorkshire are doing better than our colleagues in West Yorkshire and South Yorkshire. So we've had 4 successful placements, one of which is in York. But I think nationally, it's kind of debated whether that it is an effective scheme or not, or if we need to do more around how we can recruit and attract dentists. And then more locally, we are piloting specifically in Humber and North Yorkshire fellowship scheme. So again, this moves away from the delivery of units of dental activity and kind of guarantees a salary for new dentists coming in to be mentored and supported by experienced dentists. Like in any profession, when you're new to something, you're not going to be as quick at churning out everything. So traditionally, the contract still made you deliver all these units. Whereas if we can secure them on a salary, they can learn at the right pace, hone their skills, develop over time. So it's a really attractive scheme. And we're just trialing it at the minute to see what the impact is, because it does kind of change our contracting models. And we have one practice in York who is trialing that for us. So we're going to evaluate it and see how it's going. And we're working with Leeds Dental Institute and Workforce Training Education as well to kind of practice and see how that can develop. As I mentioned already, there's a range of national kind of focus around dental. So prior to the change of government under the Conservative Party, there was a scheme called the New Patient Premium, and that paid dental practices an extra top up to see new patients. It has been evaluated and it's found that it's not achieved what was intended. So they've actually pulled it now from April. It's no longer available. So kind of that findings from the evaluation is changed how they're going to focus that dental budget going forward. Again, under the Conservatives, they rolled out a minimum tariff. So we've gone above and beyond that in Yorkshire and Humber. So our tariff is around about £6 per head higher than the national recommended tariff. And we've also got a ring fence on dental budgets. So that's where, despite all of the pressures for the ICB and across the system to save money and really focus on kind of getting value for money, our ring fence remains in place for dental services, so we can continue to fund and make sure that that money we've got is staying within dental. Since the changes in the Labour government's now in place, you'll be well aware of the priorities that they're setting out around 700,000 new urgent dental appointments nationally, which are required. We've had our target for Humber and North Yorkshire confirmed at around about 27,000. So we're certainly reinvesting the same in 25-26 that we did in 24-25. So we're not seeing a drop in what we want to invest. And we're going to monitor that to see actually if we need to invest more or how that's going against the target. There's also a further development around prevention schemes for supervised toothbrushing, and that will be local authority led, and we'll link in really strongly again with the local authority around that piece of work. But overall, it's still looking really that we need full dental contract reform to kind of change the way dentists are commissioned to do that work, and allow ICBs to do something different to really improve things. I'm sure members might be interested to know, you might recall that previously we had a requirement to introduce a dental van. Under the Labour government now, they've said it's a choice, we don't have to do it. So we've weighed up the value for money and the focus of where that's needed, and we've concluded we can probably spend our funding elsewhere to have a bigger impact than we could through a dental van. And then we are really strongly linked in with our regional NHS England team. So they keep us updated on a fortnightly basis on developments nationally, and how priorities are changing. So at the moment, there is a lot of scrutiny and returns to the region and nationally around our plans for urgent dental appointments and our progress with the Golden Hello scheme. And in terms of public health and local authority updates, that's where Peter's paper will come in. And I suppose it's just worth mentioning as well, through the ICB, we have received some national funding to do a cardiovascular case finding pilot as well. So it's separate funding that we can't use for dental treatment, and we can only use it for taking blood pressure. But we've got 2 practices in York that are taking part in that. And basically, when you come for your dental appointment, they'll offer you a blood pressure check if you're over 40. And then depending on the outcome of that, they might issue you with a home monitor to take home with you, monitor over 7 days and bring back again. So that's kind of our opportunistic role in those public health initiatives to really identify and support wider health needs and hopefully save lives and really make a difference around detecting cardiovascular risk as well for patients. I've included some data in the paper on the final pages, so I'm sure when we come to questions, you might want to ask around that as well. So I'll hand over to Peter now, and then we can kind of have a discussion.
Thank you very much. Very comprehensive coverage. Thank you.
Thank you, Debbie. So I'll just add some things on the second paper here. It absolutely does flow from one to the other, I think. First of all, just thinking about oral health as a public health issue for the city, and I will come on a little bit later to why we don't actually know as much as we want to know about how it plays out in terms of some of the data. But in terms of what we do know, we know that around 15%, 1 in 7, probably more than 1 in 7 of our children have decayed, missing and filled teeth at age 5. We know oral health is obviously something that affects every age, and we need to be thinking about how we promote oral health at every age and stage. However, it is, like many public health issues, but possibly more than some, an exceptionally early set issue, and oral health in the first 5 years particularly, and the first 18 years, really does set the course for the rest of life, and intervening at the earliest stage is really very important. We do know something about some of the issues that our children are facing from poor oral health through the school's health and wellbeing survey. We know, for instance, that 25% of our children are reporting not brushing more than once a day. So a quarter of our children there, which don't have their healthy habits at primary school age, so that's in year 4 that survey is taken. We know that those same cohort of pupils, those year 4 pupils, reported, well, 7% of them reported missing school at some point because of tooth pain. So there's obviously links there into attendance at school and the educational disbenefits of not being there. And we just know that oral health throughout the life course is not merely an inconvenience. It can, in some cases, be particularly life-threatening. It can cause exceptional amounts of pain and distress. We know some ways in which oral health is not simply about the health of the mouth and the face area, but can in very much be a causal factor within other aspects of human health, particularly, and Debbie's mentioned work around cardiovascular disease, but particularly in terms of cardiovascular health and the strange and not 100% understood links between people who have poor oral health and a higher incidence of heart disease and stroke and those sort of things. So it's a really important topic. our population are not doing brilliantly when it comes to their oral health, and particularly our children and young people we need a special focus on. So that's the broad context of the paper that we've written from a public health point of view. And the majority of the resource and the majority of the effort within the city inevitably goes into the work of providing treatment services. But I was keen to pull out some of those preventative things on the limited resource we have available and what we try to do with that resource. It is a part of a public health duty, but it's not a mandated activity. And increasingly, as we've discussed in previous years around scrutiny, it's been very much the case that our mandated public health activities have become a broader proportion of our budget as the years have gone by and as the budget hasn't kept pace with inflation. So always bear that in mind in terms of what's being presented. But I think in terms of the resource we have available, one thing that we do really seek to do, and I would definitely say has been really fruitful over the last 2 or 3 years since integrated care boards have been in place, is to work very closely with our integrated care board colleagues on making sure that the resource is targeted in the right place. The first thing I talk about in the paper is provision of toothbrushing packs at the health visitor 9-month visit. What we found is giving people toothbrushes and toothpaste and leaving it at that doesn't work, but the support alongside it is the thing that really makes the difference. And so this is through an established relationship where every child in the city and every family in the city will see 5 contacts at least before the age of 5, if not more, if there's other needs present with the 0 to 19 service. So using that trusted relationship to build in the importance of toothbrushing at that key point, 9 months, when you're generally seeing the first eruptions, your nights are being disturbed again after perhaps getting a few months of sleep, and you're up again, and actually that's a really key time to get in with those messages. So that's the first point we do in terms of both giving out the toothbrush and toothpaste, and in terms of training and support, brushing technique, that sort of thing. Debbie's mentioned oral health promotion, and just want to explain a little bit about 2 things that are similar but different: supervised toothbrushing and then the prevention, access and treatment. In some senses, prevention, access and treatment is a step beyond supervised toothbrushing. So where supervised toothbrushing will essentially be in a setting such as a school or a nursery, the equipment is there, the toothbrush racks, the toothbrushes, the toothpaste, and you train up the staff, and essentially you put into the school day or the nursery day a small period at the start where everyone gathers around and everyone brushes their teeth together in a way that is supervised, and the staff supervising are trained. That's what supervised toothbrushing is. Prevention, access, treatment goes beyond that because it has aspects like fluoride varnish application that we obviously don't do through our nursery staff. That would be not particularly feasible to do. So the 2 schemes are related, and the situation we've got in York at the moment is that we're majority focusing on supervised toothbrushing on early years settings. All of the settings have been chosen using data which suggests that there are more children from more deprived areas in those settings. It would be wonderful to be able to use data that talked about the number of children with decayed, missing and filled teeth. Again, come on to later why that's an issue and a challenge for us. So we use, I guess, socioeconomic factors as a proxy. That's in 8 different settings when it comes to early years, and in 3 primary schools: Westfield, Clifton Green and Lakeside. So we've got a range of settings across the city where supervised toothbrushing happens. I'm aware that the prevention, access and treatment, the first rollout is in Westfield Primary in York. I'm not aware that we're beyond that, but my information may not be 100% up to date, because I think that has been a moving programme, and hoping to expand that into a couple of other settings. And where we've got supervised toothbrushing already, we'll probably actually withdraw from that setting, because PAT in some senses is a higher level of provision, so we won't double duplicate, and we'll move that provision to somewhere else. Harrogate, as I said, have been involved in a lot of the oral health promotion programs that we do. We have recently received a small uplift from the government. Didn't get into the paper because it came after the paper was written. It's £20,000 for Yorkshire. It's not a huge amount. We don't know whether it's recurrent either, but it gives us a chance to think about extending some of those programs a bit further, and really interested to hear committee's view actually on that in terms of that resource. At the moment, we're thinking about schools which are not currently in our list but are still within catchments where you might talk about the first 2 deciles of deprivation within the city. There are some schools still remaining. Should we extend to those schools? Should we think about populations within the city who are generally excluded from better healthcare and have radically worse outcomes? So we often think about asylum seekers and refugees, our Gypsy Roma traveller population, those types of groups, children in care as a group that we would almost like to guarantee that everyone in the care of the local authority has supervised toothbrushing, and thinking about communications campaigns as well around toothbrushing and how we do a really broad population message. So there's a little bit of extra resource going in there. The paper goes on to talk about dental epidemiology. This sounds very sort of wonky in a sense because it's a survey, it's a bit of public health data, but it's really important because for about 5 or 6 years, we've been really flying blind with where our children are who have the greatest level of oral health need. That is due to the fact that for the small amount of resource we've gone out to the market a number of times, and providers have quoted us, I think, what we might call silly amounts of money. So, 10 to 20 times the amount that we have in the budget to do oral epidemiology surveys where children are selected at random and we go into schools and we look at their state of their teeth. We are hoping to move on that. I can't say anything definite yet, but I'm really hoping that by the time we get to the next 5-year-old survey, which starts in September, we've got a provider in place who will be able to carry that out. Happy to update the committee on that. It's been a bit of a journey and struggle, to be honest, with the resource we have available, but I'm really hopeful that we will get there. Just a couple of additional things, and then I know we've been talking for quite a while. Just wanted to say flexible commissioning and what's available through those practices. I think my paper just goes through a little bit in terms of which practices are offering that, and just to emphasise again, that's very targeted. So the only referral routes into flexible commissioning for us are through the 0 to 19 service again, so our health visitors and school nurses, and then through social workers. So social workers can also refer in. So that's very much targeted at need. And I just thought I'd emphasise that. Obviously, Debbie's talked more at length about flexible commissioning. And I'm going to finish with the really sort of boring public health sort of message about sugar, which I'm sure we all don't want to hear, but it's not gone into either papers. And it feels remiss of me not to talk about the fact that lying behind so much oral health need is the amount of sugar that we are consuming. So WHO recommend that we should be looking at 5% of our daily calories coming from sugar. Nationally, we know for our 1 to 3-year-olds, it's 11.9%. 4 to 8 to 10-year-olds, it's 14.7%, and 11 to 18-year-olds, it's 15.6%. So 3 times the amount of sugar. I Googled on my way in here a fairly standard juice drink that I won't name, that I know my children have certainly had, and you see all over the shop, has 15 grams of sugar in, so it's already only 9 grams short of the daily allocation just in one small little bit of fruit juice. So sugar is a bit of a, well, it's not a hidden culprit, but it is a culprit behind a lot of this. So I think it'd be remiss not to think broadly across the committee about the link between oral health and the link between healthy eating, diet, the advice we give out, and the way that society supports the reduction of sugar through the things we know generally made the difference in public health, the 3 A's. So accessibility, availability, affordability, sorry, and advertising. The extent to which things are advertised and are in people's faces, the affordability, so how cheap things are, and sugar has been subject globally to very, very low taxes and tariffs, which has essentially meant it's become a very cheap ingredient for food manufacturers to put in. And then accessibility, so where we place items, and the classic thing about a supermarket checkout, the really sweet things being on there. So those are the 3 things which really drive our consumption as consumers. Thank you, Chair. I'll stop there and we can take some questions.
It's really great, very comprehensive and very interesting points on sugar there. I'm just going to take, first of all, Councillor Steels-Warshaw.
I just firstly wanted to pick up on your point around sugar and saying, Googling the amount of sugar in and looking at this, how much does come down to education? Because I don't know what amounts of sugar children are going to have. Well, we can all say that 5% of daily sugar, but I don't think we know, what does that look like? Like, is that a Mars bar? Is that a drink? And like, we don't know what it looks like. And also just the other thing we were highlighting about teeth and physical health problems it can cause. But I think what I've experienced working with people who've experienced real deprivation that has, in a sense, really damaged teeth and thing is the mental health and the long-term impact it causes, and the huge effect on people's self-esteem, not feeling like they can apply for jobs, socialize with other parents. And I think that's really important to be aware of alongside the long-term physical impacts as well. Thank you.
Okay, Councillor Rose.
Thank you, and thank you both for very comprehensive reports, but also a lot of additional information in the verbal report that added to that. I've got quite a lot of specifics on the details of both of them, but I just wanted to pick up quickly 2 things that are broader than the individual reports, just about dentistry in general in York. So the first one is, I mean, things were disastrous a couple of years ago. This when we had the report 15 to 18 months ago, things were really bad, and we had a real landscape of the scale of the problem, which this report doesn't at least talk in the same language about. Obviously, it was apocalyptic during COVID. So has that become the new normal, and that's just why it's not mentioned, or have things actually come back and improved a bit? The drop to only 1/3 of adults seeing a dentist in 2 years could be a further decline on the problem, or it could be that people don't feel there's as much of a need to see dentists. So it'd be good to get an understanding of that. And the second one related to that is, can people actually get a dentist? Lots of dentists drop clients if they haven't seen them for 2 years. So if we've got 2/3 of the city who don't have a dentist, and if they wanted an appointment, just wouldn't be able to get one, or is that changed and actually people can get one if they don't have a regular dentist, they can find one? Just those 2 bits in general. Well, what's the state of affairs in York?
Yeah, no, those are really good questions. And I think, like you've alluded to, the data shows the access for adults is dropping. And conversely, the access for children is increasing. And we don't know at this stage, because we're just doing the evaluation at the moment, but whether that increase in children's access is a result of us looking at child-only contracts, or if there's something else in that, and the unforeseen consequence of our dentists prioritising children over adults. So we need to understand that better to see what the impact is of that commissioning. But ultimately, I'd say that it is still a significant challenge trying to get an NHS dentist. Most of the dentists, I would say, across Humber and North Yorkshire and in York aren't taking new NHS patients. So it is still a case of joining waiting lists and waiting that out. There's no contractual requirement to have a waiting list either. So some practices might not have one. We do get a number of patient complaints, as you would imagine, about not being able to access a dentist. And part of our response is actually join as many waiting lists as you can. That's probably not something we should be saying as commissioners, because we also try to manage an overview of waiting lists. But ultimately, no one knows which list you're on. Being a part of one list doesn't mean you can't be part of another list. So it's in everyone's best interest to just join as many as you can. But unfortunately, that is still the state in terms of NHS dentistry. It's still really difficult to get a dentist. And that's why we're pushing, and it's really pleasing to see under the new government nationally that they want to do dental contract reform, because the feedback from our dentists is that actually the contract as it is not deliverable. That's why we're seeing new trainees moving straight into private dentistry rather than NHS dentistry. So it needs that overhaul approach nationally, really, to the dental contract.
And just one, I'll leave my other questions till everybody else has had a go, but in terms of urgent appointments, can people get those in York? There was a period of time when basically you couldn't do anything unless you needed to go to the hospital. Have we got to a point now where if you do have an urgent need, you can find an appointment, or is that still a challenge?
It's certainly improved. I won't say it's perfect. I think we still get those reports of someone ringing NHS 111 and having to travel to Leeds, but they're fewer and far between than they were previously. Yeah.
Okay, thank you very much. Councillor Fenton.
Thank you, Chair. Just picking up on, following on from the point around the decline in the proportion of adults accessing a dentist between June 23 and June 24. Is there any evidence of, I was trying to think what happened during that period. I think I know of at least one NHS practice that stopped, well, just handed their contract back. And if you wanted to stay and receive treatment from that practice, you had to go private. Could some of this decline be explained by some patients who had been accessing NHS dentistry? Their practice stops providing that service, so they stop accessing dentistry. So has there been any anecdotal or sort of quantitative information that suggests whether that's part of the reason for this?
Yeah, and I think you've picked up on a really good point, because it is over a 2-year period. So that Bupa hand back in the city was quite significant. A lot of patients were affected by that, and we'd not been able to secure a dental practice to take those patients until December 24. So that will have an impact in terms of that access. I don't know if that would account for quite the significant drop in it, but equally with the way the data's recorded, because it is over a 2-year period, the recall intervals for an adult with healthy teeth is actually 2 years. So if you've been in 2023, you actually won't appear on these figures till 2025 again. So there is kind of a bit of a delay in terms of how those appointments might go in. Nationally, as you can see, there's the England line, so it's also falling across England, and it's also falling across the ICB as a whole, although only slightly. So there is some sort of trend there, but it's will be linked to local issues like the one you've highlighted for York and contract handbacks, but there's likely to be something else going on within that as well.
Councillor Vassie.
Thank you, Chair. And I'll start with an example of why it is that written reports are never the be-all and end-all. As I understand it, and you can correct me if I'm wrong, 5 grams of sugar is a heaped teaspoon, and the average can of fizzy drink contains 8 of those in a single can of drink. And I think sometimes just visualizing that data is part of the challenge. We simply can't get it from just picking up a can of drink and having any understanding of what's actually dissolved in it. So moving on, I'd like to celebrate the fact that the supervised toothbrushing programme in York schools started here in Scrutiny. In late 2022, we raised the issue. Officers ran with it, and within 6 months, a scheme started in 6 schools, and we had a report back 15 months ago, a year ago, that said how successful it had been and how it was successful with the children, with the teachers, and with the parents. And that really brought joy to me. I'm proud of that because it shows that Scrutiny at its best achieves and helps contribute to positive outcomes. I'm pleased to hear that the same approach is now spreading out far and wide. I think that's great. I mean, we can't pretend it originated here in York. I mean, I know there are schools around the world that have it, but we started doing it here, and I'm really proud of that. In terms of questions, you mention in here about a dental van having been looked at and then being discounted. And you also talked about preventative care for schools. Is there a part to play in making sure, or make sure I've understood what you said maybe? This preventative treatment, does that involve checkups of all the children, proper checkups when the dentists arrive? And I ask because I'm aware when we look at deprivation broadly across the city, my ward doesn't feature in it, and I get that. But I also know as a councillor that there are pockets of deprivation in my ward. There are pockets of housing where people are isolated, where they don't have cars, where there isn't a bus service, and where I worry that those people don't have access to dental care, and the children don't grow up in a household where there's access to dental care. So could you maybe just explain a bit more how in the year ahead we're going to make sure that those kinds of children, as well as all the children in areas of deprivation across the city, are not missed out?
Yeah, certainly. And I think with the Prevention Access and Treatment Programme, we've got a team of dentists and dental nurses going into the schools, and they provide that fluoride varnish that Peter was talking about. So as well as doing supervised toothbrushing, they'll actually look in the children's mouth and apply that fluoride varnish, which helps then to prevent further dental decay. But while they're looking in the mouth, if they notice actually that child has a lot of decay or other issues going on, that child will be invited for an appointment at the dental practice, and all the members of their family will also be invited, looking at probably things like diet, that within the family they could all benefit from that support. So they're all offered that opportunity to come into the dental practice for an appointment. And I think going forward, Peter mentioned one of the schools in York that's part of the scheme. We are just in that process of rolling it out wider. As I said, it started in Hull and East Riding, and we're starting to work with local authorities to identify the right schools, link with dental practices to ensure that we've got a practice linked up that's close by so people can access as near to home as possible. So that process takes a bit of matching and figuring out, but we'll work with local authority colleagues to kind of prioritise which schools, who's likely to engage with the scheme or not, which areas of deprivation, and what those needs are of the children within that school. And on top of that as well, I suppose through flexible commissioning, the list within Peter's report is subject to change. So we're expanding the scheme and changing it ever so slightly. So some of those practices might opt out, but we might get new ones coming on. So we're just working with them at the minute to finalise that. But an element of the new scheme is actually that, as well as accepting referrals from health visitors and social workers, we're also expanding it to accept referrals from GPs. So if you've got an adult with a long-term health condition and they've also got dental issues, GPs can now refer. We're also prioritising refugees and asylum seekers. And there's a whole list, can't think of them all, quite a lot of vulnerable groups on that list now that can be referred by other professionals, not just in terms of you're known to your GP for a long-term health condition, I'll refer you to get regular access to a dentist. They'll still have to present and have a dental issue, but they would have an easier route to get seen by a dentist, recognising that those vulnerabilities and longer, wider health conditions actually can often present or affect your oral health as well.
Yes, sir.
Thank you for all of that. That's good to hear. You mentioned earlier on about combining dental services with cardiovascular checks. And it's great to hear, because that's, if integrated care means anything, that has to be it, doesn't it? In terms of, and again, going back to this dental van thing, there are care homes dotted about the place. And we know during COVID, there were people there who weren't seeing a dentist of any type over the whole of that period. And many of them, it was no doubt with false teeth, but dental oral health it applies to everyone, doesn't it? So I'm just wondering, again, you know, if there's why it's considered not value for money to do the kind of thing that's I think was done 20 years ago of having a visiting van that would arrive somewhere and people could have various checks. Why is that not considered worth progressing at the moment for those communities outside York?
No, that's really a good question as well. I think there's probably two aspects with that. One is in terms of domiciliary dental services, which are those services that will come out to people living in care homes or to people unable to leave their own homes. We do have a provider who will travel around and actually see people on that need basis. And if any referrals, say, to community dental services are required, if they have reduced mobility or need special adaptations made to access a practice, they can make those referrals for them as well. So we do have that sort of service through domiciliary dental, which we're also looking at the moment. We've got a task and finish group. We want to expand what we're offering in terms of domiciliary dental, recognising that there is a large and growing need of people living in care homes or being maintained to stay in their own homes and be looked after there. So we really want to expand that service. And in terms of a dental van itself, I suppose the requirement from the national government was that we would have a dental van that would travel to communities that didn't have a local dental practice. And we were always debating kind of whether that was geography based or whether it was community based. So is it easier to bring one into the city centre and people come and access it? Or are we saying actually we need to take it to rural North Yorkshire where they're travelling 30, 50 miles to see their local dentist? And that was where the value for money aspect came in, because actually if you bring it to a city centre location and people just present, you don't know what you're going to be dealing with, and you can only deal with a certain type of dental issue within a van. You can't necessarily do the full remit of services. So then where do we signpost them to for the actual treatment that they need? And then equally, if we're travelling around to rural areas, that same situation would apply where we're not sure what dental needs would be presented. But it's you need drivers, you need staff, you need planning to get vans parked in the right locations, etc. And it would just take a lot of commissioner time to plan that and resources from a dental provider to manage that process. So overall, that's kind of where it was found to go, actually, we get better access if we put that money into dental practices and increase the number of urgent appointments or increase the number of child-only contracts, etc. So that was how it was decided to move it elsewhere.
Okay, thank you. So it's Councillor Wilson, then Councillor Waller, then Councillor Runciman, unfortunately. Sorry.
Thanks, Chair. So my first question was just going to be about the child-only commissioning and what the barriers were to other practices signing up for it. So you said you've got 4 at the moment. I just wondered what sort of things were getting in the way of other people signing up for it.
I suppose it was actually our ICB finances around it and what we could actually invest in it. So we had to manage those requests and look at distribution across the ICB, and then in places like York, looking at where those practices were located and if it was easier in terms of transport corridors to come into the city centre or out around the ring road, etc. So it was more of our kind of funding position.
So Councillor Waller.
Thank you, Chair. Following the reports, it is an issue that I've had a lot of correspondence over the years, over the last 25 years. Access to NHS dentistry has been a perennial problem that has peaked and troughed. But it is important to get that access before crisis, because the consequence, I've seen it too often. The early intervention is important, and as a governor at Westfield, I'm very conscious of days lost and the impact it has at home, that the children in the house can't sleep. But I hope that this can be done universally across the city. I don't wish to see Westfield stigmatised like this, because it's an issue that affects children across the whole city. Communication is important, and having seen on social media that bizarrely this has become a feature of the culture wars, that what was perfectly reasonable for the last 50 years in terms of showing young children the best way to brush their teeth is suddenly seen as a massive intervention, and I think it's important to get across the benefits of just rehearsing the importance of proper toothbrushing, which I should imagine everyone's had it at primary school. That this is a perfectly normal thing to do, and it could be, as the discussion has linked in the amount of sugar in many of the drinks that we have, that there are those plastic wrapper things that show you that in this can there's this much sugar and that much sugar and ridiculous amount of sugar, which is sort of hidden, but you know it's there. I think the sense that it's just a reminder that these things are linked, and there's very interesting study done with looking at the population who acquired their eating habits before sugar came off rationing, compared to those who were just a little bit younger, and the impact that has had on their health over the intervening period. So I think it is an important thing to get the science explained in a way that you bring the public on board, and that has the lasting impact on improving dental health from the very beginning. But also I am concerned about some of the things that might fall between the cracks with all of the recent sudden changes. And you know, on Monday, the corporate parenting, that issue was flagged up, and I wouldn't want to see children in care missing out because of a bureaucratic upheaval that has suddenly been hit upon the nation as a whole. Thank you, Chair.
Sorry, Councillor Runciman, would you mind if Councillor Steels-Warshaw just wants to respond to that? I've been waiting very patiently.
Sorry, it was more of a comment from the corporate parenting board that Councillor Waller and I were just both at on Monday, and we were talking about the dentist offer for young people leaving care as well, which York is pretty good at its dental offer, but I think it's just refining that for the young people who are leaving care, but also within that, what age would it go up to, I think was also a discussion, because would it go up to 18, or if the person had an EHCP, could it go up to 25? Would that be able to happen? And I think, just to add on to Councillor Waller's comments from the corporate parenting board. Thank you.
Okay.
Yeah, if I can just respond to that. In terms of the flexible commissioning practices, children in care were always on the list, and the new list now has care leavers as well. So I definitely know they're on that list. In terms of the age, I don't know what that is off the top of my head, but we can certainly look it up. And I'm very familiar with the EHC plans going up to 25, and that's what I would expect is there, but I don't want to promise it. Yeah.
Thank you. And last but not least, Councillor Runciman. Oh,
Thank
okay.
you. Trying to just bring everything to mind. I wanted to ask, the children, there's an increase, which is good to see. I've got two questions really, but do we know if those children are going for checkups or treatment, or even, I suppose, extractions? Do you have any analysis? You know, we can say 71.1 in that period of time, but what are they going for? And then I'll ask the second question when that's finished.
Yes, so we don't know, we just know that it's an individual child. So we don't know what they've actually gone for. Our dentists anecdotally do tell us that quite a lot of the children are having just a routine checkup and early treatment. But there will be cases of children with multiple levels of decay as well that are treated within that, but we don't know the exact breakdown.
It would be interesting to know though, wouldn't it? Because it's going to relate to the second question, which is the supervised toothbrushing. Is there any longitudinal study which tells us the children go on brushing their teeth and as a result have less dental caries? Because that's what we'd all like to see.
I think simple answer to that, Councillor Osmond, is yes. I think supervised toothbrushing has a really good evidence base in terms of the behaviours that are then carried forward into teenage and later life in terms of, you know, just certain things such as the, you know, 2 minutes to brush your teeth, brushing in circles, just, you know, certain things like that. In terms of the actual caries within the teeth, I'd have to go away and look at that. And I'm presuming, given that it's a highly evidence-based program that's been used in several countries, that it's not just shown impact on people's behaviours and activity, but actually on the outcomes. Debbie may know if it has done, but I presume it does. I can find out if we don't know between us. Okay, we don't know between us, and we can find out.
It's a long answer, but you don't know. And I'm going to ask one little extra one. Do we know if it affects toothbrushing in the family? Because the child is brushing at school, do we know if the siblings then might brush their teeth or they didn't before, or the adults who also might not brush their teeth, but who now do, because children can be very influential in saying, well, that's what Miss says I got to do and you've got to do it too, or similar. Yeah.
Well, if it follows other patterns, I'd say yes, because we see in other areas of behaviour when one family member starts changing, and diet would be a good example of that, physical activity another good example. That often does, as you say, it does ripple through the family. I can't point to the study right here and now that shows that, but I suspect it does.
A comment, it would be a very interesting piece of research.
Councillor Rose, you.
Yeah, thank you. I'll pick all the rest of my ones up, minus the ones that have been answered. Thank you very much, and minus some for time. One quick point and a question on the public health side. So I certainly back the points that were made around deprivation outside of areas of deprivation, if that makes sense. And I think this is going to be an ongoing, growing problem in York. You can get a static caravan within 10 miles of York for 60 grand. You can't get a house. And we're going to find that is an ever increasing challenge, that there are these areas within affluent wards that aren't as easy to spot on a map that we do need to think about, and it isn't dentistry related, it's public health more broadly. So it's something for us to think about offline, perhaps. Picking on the point you mentioned, every age and stage, Peter, and then we had lots of training programs for early years, 0 to 19s. Obviously demonstrable progress in that area, whether it's directly related or otherwise. But what is the equivalent as opposed to mass comms for adults? What is the training equivalent that we can have for adult populations? It feels very condescending to say that people need training on how to brush their teeth, but the reality is probably there are people who would benefit from that. What do we do? What could we do?
Yeah, to take them in turn, Councillor Rose. I mean, first, I would say, looking at what we've outlined for the committee today, the approach we've taken is really in line with my professional sort of view on the way we should run public health programs. It's what Professor Michael Marmot called proportionate universalism. And it is essentially that we need to have universal approaches across the whole population to improving health, but they should be proportionally weighted towards more deprived areas. And unfortunately, and this is not a York issue, it's a national issue, that when we talk about deprivation, we have to use very crude geographical chunks. There's 120 of them in the city, and we all know that within the 120 you will find the more deprived areas which have people in with high levels of means, and the less deprived areas where you find people within with low level of means. It's a population statistic, it's not an individual judgment. So in that sense, it is very crude. It's the best we have to do that proportionate bit. And what you find with, for instance, the supervised toothbrushing and the prevention, access and treatment is at that proportionate end. At the universal end would be oral health campaigns, would be health visitors giving out toothbrushes to all children, and probably actually, even though it's targeted, but the universal aspects of flexible commissioning, where you could be in any ward or any postcode in the city, but if you have the identified need, you can find your way through. So my judgment, what we've got there is a programme where, yes, we do have resources going disproportionately to the crudely more deprived areas, because that is the right thing to do. There's the evidence-based way we level up and reduce the inequalities, but we still have a universal offer in several aspects of what we're providing. And we will never get the 100% right, and there are always different ways you can cut that. But I think what's presented is on a budget of around about £20,000, which is not an awful lot of public money, what we're able to do. Your second question, remind me, I'm sorry, I've waffled on for so long, I forgot. Adults. Well, it's a really good question, actually. And the answer is there's not a lot of publicly funded programs. I guess when we're talking about adults, we might think about some adults where we might find higher levels of dental decay, and some adults where there may be more of a role in helping and supervising their toothbrushing, but for many that's just not a feasible thing that we do. We obviously do talk openly about oral health. We often encourage people to seek checkups, and I think even though that is an issue and a difficulty, I think it is important to just with some simple messaging, which would be that there is no right or wrong answer to the question, how often should I see my dentist? But essentially every 24 months is sufficient for those with healthy teeth, and it's up to the dentist to make the judgment on seeing more frequently than that if you have a history of dental issues, dental decay. Many people assume that every 6 months is for the whole population, and it's not. It's if you've got healthy teeth and gums, it's for 24 months. So trying to reinforce messages like that, trying to reinforce the prevention messages about levels of sugar consumption, and Eka points around sort of how difficult it is to estimate that. But yeah, unfortunately, we don't have any programs of work where we're really actively intervening in those areas, and that may be something we could consider what the evidence says, and particularly thinking about care homes, thinking about other settings where we may be able to introduce things in a defined way, might be something that we look at in the future. And I'm sure probably other areas may have had the capacity to think about their older populations in the way that we haven't.
Thanks. And yeah, I mean, very limited budgets, so the ability for us to do much that's targeted is difficult. But I guess that the broad comms piece, we know that the majority haven't seen a dentist in the last 2 years. So whatever that messaging is, whether that's because of a lack of education or a lack of activity, we don't have a capacity if everybody did try and see a dentist every 2 years at the moment. So something to think about. A couple of questions for ICB side, if that's all right. You mentioned about recruitment, including areas of deprivation and that whole piece. I just wanted to understand, are we all pinching the same staff, including newly qualified dentists? Are we coaxing people out of retirement or who've had a career change in the past? If somebody in York wanted to retrain as a dentist, do they have to leave York to do so? What does that landscape look like in York specifically?
I suppose overall for York specifically, I don't know the actual position for York, but in Humber, North Yorkshire, That's why we work really closely with West Yorkshire and South Yorkshire as well. They've got in West and South dental institutes where they do training. We've not got one in Humber, North Yorkshire. So we do find if you want to train, you have to go to those areas. Sometimes you stay there, sometimes you come home, and it's how we can make it attractive for people to come home. But equally, I'm linking in with LDC colleagues, who's our local dental council, and workforce training education. It happens our clinical lead for dentistry in the ICB also works at WTE around the training. And we're trying to look at, well, how can we promote local young people wanting a career in dentistry to then get them trained and bring them back and to get them to work within the NHS. There's, like with medical courses, there's an entry requirement, and there's a discussion actually that why are we setting that bar so high? We should actually, anything you need to learn, you'll learn on the course. So could we lower that entry requirement as well to attract, again, a career path for a wider community rather than at the moment, it seems from WTE colleagues, they're saying most people enrolling onto dental courses are from middle class families, whereas actually in the past they were working class families. So they're trying to look at, well, what's changed that curve and is there something we can do differently around that? So it's certainly something we're aware of and that we're looking at. But you're right, in terms of people wanting to train, will have to go to South Yorkshire, West Yorkshire, to those dental institutes to do that training.
Thanks. I think that's obviously it takes time to train dentists as well on top of that, but it's a real problem if you have to send people to live away from your region to be able to train, because if you then live somewhere for a period of time, why would you want to be coaxed back necessarily? You know, it can happen, but if there are people in York who genuinely are wanting to retrain, but they have a family in York, they're not going to upship just to do training potentially. So, or at least it's a barrier. Last question from me is around the finance piece. So, great. The ICB's invited the over deliver about to 10%, and we'll cover the costs of it. That's fantastic. Also good that you've talked about making sure we've got at least the same investment. Potentially we'll grow that investment based on need. I guess my question is, where's the elastic money coming from? Is that 10% extra covered by the fact that we have a 10% loss across dentistry from what we should have, and so it's the same budget, but we're just kind of finding that flex within it? Or, you know, how do we go above the cap of finance? What's that money going away from if it is going into dentistry?
Yeah, exactly. You've understood that perfectly. So we've kind of got two budgets in terms of our finances. So that first budget is for all of our contracted activities. So that's all earmarked, all spent as per what we've contracted for. When those providers don't deliver, so they're not delivering those numbers of units of dental activity, at the end of the financial year, we do an audit and a recall. So they have to pay it all back to us. And then that is the non-recurrent part that we can then reinvest into urgent access. So ultimately, the long-term plan is if we get our contracting and commissioning right and everyone's delivering, we're going to get less and less clawback, which means less and less reinvestment. And so it is quite difficult because that clawback allows us to be creative, to try these new pilots, to reinvest in things like urgent dental. But ultimately, we are aiming to get them all delivering to their contracts fully, which then will affect that budget. So year on year, our non-recurrent part changes depending on how well they're performing, and which is also why we don't know until we actually get the year-end figures. So then there's like a mad kind of rush. If we're lucky, about 9 months in the year to then try to get that spent. And that's why we're in the position like we have been, where in March we've said, actually, we've got a bit more so everyone can do more. But it's quite an unknown kind of changeable budget that we've got for that non-recurrent investment. And nationally, from the government themselves, that's where they've still said that we'll have a ring fence on dental budget spending. So rather than that clawback coming back and going to hospital trusts or somewhere else to cover the ICB's bottom line, it's clearly ring fence still for dentistry, which is positive.
It's very good to hear. Councillor Wilson, then Councillor Runciman. Then I think we'll
thank you, Chair. So my first one was just a bit of I was just thinking about teaching in schools and knowing that we teach healthy plates in Key Stage 1, we do teeth in lower key stage 2, we look again at healthy diets in key stage 2 and thinking that surely there's some way that we can link in the sugar knowledge with what schools already have to do because it's part of the national curriculum, and particularly for those schools where you're going in anyway and teaching them how to clean teeth. It feels like there's some quite nice dovetailing that could happen. So places like Ealing offer like a sugar smart thing to all the schools in their authority so that they have some additional training. And I feel like that might be something that's worth exploring about how I've seen those sugar displays. In fact, I'm sure I had one in my classroom at one point where we had all the pictures of the drinks and we had the amounts of sugar in. So it was like a really visual thing for kids to take home and talk about. And we did stuff with parents, but I feel like there's possibly some work there that's wouldn't be very expensive because we're already doing it. Apologies if you're already on that train. So that was my first point. And my second point was, again, me just mulling over, but thinking about possibly why child-centred practices might not work as well is those, speaking from personal experience, young children's first experience of dentists are often going with their parents. So there's that gap where if children don't experience that, going to the dentist is quite tricky. And then obviously with the what's presenting means that your experience of the dentist is not very nice, that you end up in that sort of spiral. And also thinking of neurodiversity and how you encourage those young people to access the dentist. Again, if they've been going to the same one, like my neurodiverse child has no issue with the dentist, but we've moved practices because they shut and opened, but she's been seeing dentists the whole time. It's been very joined up, so that if we can get those bits right, some of those problems will be solved. But I don't know if there's any sort of question there, other than possibly the stuff with schools, but thank you.
I'll answer that that first one in terms of what we do in schools. So the Sugar Smart programme was really helpful and effective. It was a public health England campaign that is a little old now. Our main intervention in schools is the Healthy Schools programme. So a set of resources that we have in conjunction with North Yorkshire and an awards programme where schools are working towards bronze, silver and gold levels of achievement. In order to achieve the bronze level, there is a healthy eating module that has to be achieved by a school, and we support schools with training and with resources in order to achieve that, and then they have to send off their submissions to the panel, which look at what they're able to do. So that's the key bit that we have that goes above and beyond the curriculum. Absolutely right, the curriculum has elements of that, but we're also working with pastoral leads across schools as well to try and support all schools in York, whether or not they feel they can go for the award, on essentially a range of different public health issues and bringing it together, because I personally feel that we could go further in the city in terms of our schools as healthy places and settings. If you think about, all children spending a third of their day, and one of the other thirds is asleep. So one of the 2/3 of the day that you're awake in a school setting, it's so important to get those as supporting health as possible. And we are doing work around vaping in schools. We do work around alcohol and substances. We do work around domestic abuse, Operation Empower, those sort of things. Police Run and the Healthy Schools Award. And then we survey children every couple of years. There's an awful lot of activity, and we're really trying to coordinate it now so that all schools in York have a really clear approach to public health and prevention. So I think, it's a bit of a sort of watch this space for some of that work. At the moment, it's just the Healthy Schools Award, but I would hope that would expand as the years go by, because I absolutely agree, it's really important. And I love, Sugar Smart. So using those campaigns materials, they're probably freely available still on the Department of Health Social Care website. So I really encourage everyone to do that.
Just a very minor point, because I'm sure many teacher friends are watching it, but I do keep having the point made by colleagues who are still teachers saying that they are having to do too much. So it's that balance between the stretch that every person in schools, and I'm sure Councillor Waller knows, being a governor, that they are overstretched anyway, and feeling that I had somebody moan at me about the toothbrushing which was quite funny knowing I was coming to this, just because it's another thing that they have to do. So I'll make that small point as well, but thank you.
Okay, councillor Runciman.
I'll be quick, Chair, promise.
It's a
Just going back to what Councillor Wilson said, very important to take children to the dentist with you as an adult. I can remember taking my daughter with me when I think she was about 18 months, perhaps 2 years. I was registered at Leeds Dental Hospital. And so she was always used to going to the dentist. Didn't faze her at all. But I can assure Councillor Rose that trying to run a dental hospital or a dental school is ferociously expensive. And I have actually talked to one of the VCs over here about doing it, and it's the cost element that would put people off. And then the last thing I want to say, I hope, and I'm not going to put it as a question because the chair wants us to finish, I would hope we'll see less extractions of first teeth under anaesthetic. And I hope that the hospital will be able to tell us that as a result of supervised toothbrushing.
councillor Vassy would like to say one last thing.
In a sense, councillor Runciman stole my thunder. I was just going to say, could we next time we have this have included the figure on emergency extractions in the hospital, because that would be a pointer, wouldn't it, going forward, to give us an indicator of how things have changed over time. And just a last point, as Councillor Wilson brought up, kids and dentists. I knew we were going to be all right with my youngest daughter when she finally came out of the dentist, seeing, I wish my dentist was my mum, was my mum, was my mum. And we realised we'd actually found someone that was going to help.
That's incredible. Right. I shall just okay, yeah. We all should go to that dentist. The only thing that strikes me though is that
slightly creepy, even, I must say.
The problem is that if there aren't the dentists there for the adults to go to then go with their parents. I mean, what I am pleased to see is that there are good initiatives going on and that children are going to the dentist, because it's heartbreaking to think that they can't go and that their dental health will be badly impacted. And it's really sad to hear of so many extractions going on in children. I mean, I remember the school dentist coming around and checking all our teeth. But I also remember just a few years back having no NHS dentist because mine had retired and no one took over the practice. I was left in limbo and I ended up in Leeds and then touring round in Leeds to find. I went to the dental hospital, queued. I was just under the threshold, so then I had to hang around for more hours with this ferocious toothache and seeing a sort of a great emergency dentist just in a building that seemed to have been built in a car park. So I think things have improved since then slightly, but I did end up going to the school dentist by 111 in Monkgate, and it felt like I'd gone in a big circle. And I was, a regular attender at the dentist as a child, so a great deal of experience. I also had the fluoride coating, and I've got one filling. So I don't know how effective that is. I did find that interesting because I remember being in the first sort of cohort of children in the 60s to have that. So
I would just quickly add in there, and if we're talking about effective programs, supervised toothbrushing is effective. Fluoride varnish is very effective. There's one we haven't mentioned so far this evening, but I thought I should, which is water fluoridation, just because there is a North East trial at the moment, which is been going on. So in the North East, adding fluoride to water has been trialled by the government. It's already in some places in the North East, it's being added to others. A large portion of the UK has already got fluoridated water naturally, and that, in terms of prevention of dental caries, is off the charts when it comes to prevention of those things. So yeah, thought I'd throw that one in.
Then it starts getting a bit controversial.
It does.
Yes.
I thought I'd give you some controversy to end your meeting.
Yeah. So going back to what we discussed at first with you, Peter, we talked about less use of sugar needed and a link between oral health and healthy eating, and the recommendations that we could give tonight. So tonight, which was accessibility where sweets are placed in in supermarkets and shops, whether we could recommend something about that, and advertising, less advertising, also taxes on sugar. I mean, there's nothing to stop us recommending these things as a scrutiny group. Whether or not they will be put into action, we don't know, because it seems to come in waves, that one minute we're having taxes on sugar, the next minute we're not. We can't, I don't think we can count on that, but we can recommend. I don't know how we'd all feel about recommending those things. I would be hesitant to recommend fluoridization of water, but I don't know. I don't think we'll vote on it. Councillor Fenton.
I mean, I think in supermarkets, I think the penny has dropped, and it's very rarely that you'll see sweets next to the checkout. You see a lot of other things next to the checkout that you don't need but could be persuaded to buy. But I think that's that's kind of moved on, and you know, there has been debate about advertising, but you know, the council's settled policy is that when it goes out, well, it has awarded a tender for advertising infrastructure and bus shelters, and the the prohibition on certain food types is baked into that policy. So I don't think we need to recommend it. I think it's a done deal, whether you like it or not.
Councillor Rose.
Yeah, I mean, what I will say to that is supermarkets perhaps, but if you go near any petrol station in the UK, you might find quite a lot of chocolate next to the till. It depends on the place that you're in, I think. But yeah, I agree. I think within the council agreement, there's not much we can do. We can write a letter to both of our MPs. I have no objection to us doing that. But I think yeah, that progress is there. Tariffs is slightly different to taxes, and I think tariffs is particularly manufacturing is a big one. But then we also in York have Nestle at home to consider about the impact on us from that. But yeah, and water fluoridation was in the report, so I think we all chose not to ask questions about it. But it was a good one to raise. But I think if there's a pilot underway and we've seen success elsewhere, the fact that it might be controversial in some ethereal sense, it's not controversial if the demonstration's there that it's safe and
I think for some people it has contraindications, but anyway, I don't know too much about that. So sorry, Peter.
Well, I was going to suggest, Chair, I think on the work programme we've had for a while, an item around healthy weight, and particularly thinking about sort of children, young people, and the approach that we are developing across this year that we're calling the compassionate approach to healthy weight. So moving our healthy weight work away from very stratified sort of tier 1, tier 2, tier 3 weight management in a quite clinical way of thinking about it, into talking and having better public conversations about weight and food and trying to make sure our language isn't stigmatizing, for instance, and all that sort of thing, alongside being clearer about the things which really determine our eating and our oral health, which are often outside the control of our citizens. And we can tell people as much as we want, but the nudges are there. So I think that's a future item on a work plan. I wonder if that more fulsome conversation about some of those policy things and what committee may or may not want to recommend in terms of any local policies we have or national policies we might want to feed into. I wonder if that would come at that point, because I think it is essentially probably the same question, just on a different bit around healthy weight.
Okay, fine. And I think James is noting that down. So certainly more supervised toothbrushing in schools, because that's having a good knock-on effect within the family too, something that I hadn't realised, which is and then and the universal approach to that, rather than just being in the deprived areas, so that everyone is taken in by that, I think. But great that's going on, and those initiatives, I mean, we seem to be bearing fruit in the visits to dentists that we saw from your report, Debbie. So I think we've really had a comprehensive overhaul of all dentistry in York. But Councillor Rose just wants to have a last word.
Well, I was expecting you to ask if anybody else had any recommendations, but lacking that, I'll throw in anyway. On top of the challenges around finance, which again has to be national and through the MP and the stuff we've just talked about on local interventions, the challenge that we have of having no ability to home grow dentists, I think is one that it warrants us leaning into the ICB more. And it's an ICB thing, not for us, and it's the whole region, not just York. But I think sending people away and hoping they come back isn't the best way of growing long-term dentist numbers in the city. And anything that we can do as a council and public health team and councillors to support the ICB in that mission, I think would be a wise one. In terms of recommendation, I don't know what we have within our powers, but
we can recommend.
Yeah.
We might not. I mean, my other thought on that was in the old days, you could maybe write into a contract when people got a grant to do something that they gave some time back to the NHS. But now people are taking on huge loans. Then it's really, I suppose, up to them how they choose to use their skills, which it's rather sad having, yeah. Any other recommendations here? No. So Debbie, sorry.
So I was just going to add to that as well. We are looking at, in particular in Bridlington on the east coast, we're really struggling to recruit dentists there, and we're looking to engage with the local authority to see actually how we can work together to offer incentives, whether it's things around housing or helping to find premises to put in a dental practice, etc. So I think that kind of learning and that type of partnership approach that Councillor Rose has described in working with the local authorities is really welcomed by the ICB. So we would be really happy to work with York and see what your ideas are around what we could do more locally as well.
Yes. Well, can I just thank everybody here tonight for their contributions on this item? I don't think anyone else has got anything else to say. So thank you both for your time. It's been a really, we have some very good debates, I think, on this committee. We've already covered the work plan. There's no urgent business, so call an end to tonight's committee meeting, and thank you all for your contributions.
thank you for your chair.